All right, well, we'll go ahead and get started with today's session. Shelby, if you want to introduce us.
Yes, thank you. So Project Echo is a program that helps share. Oh, we can see your teams, Krista, just an FYI.
My PowerPoint just quit. Sorry about that, everybody. Never have we ever had this happen.
Well, I'll just do my spiel anyways. Project
Perfect.
Echo is a program that helps share specialized knowledge with professionals. It connects subject matter experts with community providers through virtual sessions, making it easier to learn and collaborate. Project Echo gives professionals the tools to provide better care and support, especially in rural and underserved areas. The goal of Project Echo is to share knowledge more widely, reduce gaps in services, and create a system where everyone learns from each other. This Echo series is sponsored by the North Dakota Early Hearing Detection and Intervention, or EHDI program. The purpose of the series is to enhance knowledge of the EHDI system. Our goal is to build state and territory level data and measurement capacity to improve language acquisition outcomes for children who are deaf or hard of hearing. Before we begin, I'll describe an Echo session and what sets it apart from other trainings. In essence, Echo sessions allow us to move information, not people. It allows you, the participant, to actively learn about a topic and ultimately become a resource for your community. Each session, there will be a formal didactic portion on a designated topic, and then it will be followed by a case presentation. We encourage you to take part in the case presentations during group discussions by unmuting or using the chat. Your participation is key to the success of these sessions. We aim to create an interactive community where our presenters, stakeholders, and community members all communicate and support each other during the session. We encourage everyone to turn off cameras throughout the session as long as you're comfortable. Encourage you to be engaged by asking questions and provide feedback. Individual privacy is of utmost importance to us when sharing information during our case study discussion. Please avoid using real names or initials. Please do not identify any individual's family members, friends, coworkers, or email addresses. Your attention to confidentiality helps us create a safe and respectful environment for everyone. To receive credit for your attendance today, please fill out the evaluation that will be sent to you after the session. You can earn professional development credits in social work or a certificate of completion for your participation. Your feedback is important to us, so thank you in advance for taking the time to complete those evaluations. Just a few housekeeping notes. Each week, iEcho will email you a Zoom link to join the session an hour before the session begins. If you have not received a calendar invite for the series, you can download it from the website. We will post the recordings and handouts in iEcho under the Content tab. Please allow up to a week for recordings to be posted. And today I will introduce our speaker, Dr. McCann, who brings a wealth of knowledge to our session. Dr. McCann is a faculty member in the Speech-Language Pathology program at Gallaudet University. His teaching and research interests are in language and literacy acquisition in deaf and hard of hearing children. He serves as the Speech and Language Services Specialist for the Beacon Center. Prior to joining Gallaudet, he worked as an SLP, providing services to deaf and hard of hearing children and their families in the infant, toddler, early childhood, elementary, high school, and deafblind programs.
Okay, so I will go ahead and share my screen then. That's what time it is?
Yes, it's all you.
Yes, okay. Let me. All right. Not in the beginning. Let me move back to the beginning. Hello, welcome everybody. Thank you so much for having me. I'm really excited to be here today to talk about the EHDI and specifically how it relates to language acquisition. So I'm thrilled to be here. I saw in the chat there seems to be quite a diversity of backgrounds here and even states and locations and occupations. So it's great to have a collaborative interprofessional audience to talk to and interact with. So we'll go ahead and get started. As shall be mentioned, my name is Jim McCann. I go by Jim, and I am the speech-language services specialist in the Beacon Center. And so, as mentioned in this, I'm going to try and find the chat too. So if there's anyone who wants to comment at any time, ask a question, feel free to unmute yourself, or I'll try and see if I can keep my eye on the chat too. But if I don't, if someone can give me a heads up that there's something there. I'm going to be sharing a lot of information, but I know that there's a wealth of experience and knowledge in the audience as well. So if you have any comments or questions or feedback, feel free to chime in. It makes the interaction even better. So just to give a little bit more background about myself. So as Shelby mentioned, I am a faculty in the speech-language pathology program. So I train graduate students who are going out into the field to become speech-language pathologists. I am fortunate that at Gallaudet, we do have a specialization in working with deaf and hard of hearing kids through multiple classes with oral rehabilitation. And we also focus some of our child language curriculum towards deaf and hard of hearing. So it's a really exciting place to be in terms of EHDI work. Again, my background is as a speech-language pathologist, so I spent over 20 years in the field working across the age span. So it's really interesting to have seen not only the early intervention, but also what the long-term outcomes look like. And I actually started practicing around the time when EHDI was being implemented. So seeing that shift and what kind of exciting and positive changes have occurred since we started catching childhood hearing loss earlier and earlier, and seeing what kind of progress we made, but also seeing all the barriers that still exist and kind of seeing what possibilities are for progress in the future. So I'm excited to have this conversation related to how EHDI relates to language acquisition. So the objectives for today is that we'll kind of describe the EHDI system. We won't spend a whole lot of time with that. Shelby mentioned that the background from the audience seems that people are pretty familiar with it, so we'll just go through that very quickly. Then we'll talk about the importance of early detection of hearing loss on language acquisition outcomes, identify the role of stakeholders involved in the EHDI system, identify some effective communication strategies for engaging families during the EHDI process, and then identify some of those barriers and possible solutions that still exist. As I mentioned, we've made a lot of progress in the area of EHDI, but there's still a lot of room to grow and a lot of families that are being underserved that if we can identify what these barriers are and think of potential solutions, maybe we can engage even more families in the EHDI process. And then also explain how the positive outcomes are that occur with timely EHDI involvement and meeting those 136 guidelines. So first, just the overall of the EHDI system is that it's an approach to identifying hearing loss in newborns and young children and providing timely intervention to support developmental outcomes. That's the goal. The goal is to find these kids early so that we can provide families with intervention that will support developmental outcomes across language and all of the related areas like social emotional development, play development, and those kinds of things. We know it's coordinated by the 3 Health and Human Services agencies listed there, and also that the Joint Committee on Infant Hearing provides some expert guidance in terms of policies and recommendations and practice recommendations for screening, intervention, and diagnosis. And I'll refer to several of these recommendations as we go through looking at the relationship between early identification of hearing loss and language outcomes. So again, we're all familiar. The goal is to reduce the negative developmental impact. I think on North Dakota's Ed.D website, they have the statement that hearing loss is a developmental emergency. So that's what we're here to kind of get to, is figure out how do we prevent the outcomes that often accompany hearing loss in development of young children. And to do this, we have the goal, the 136 goal of screening all infants by 1 month of age, and then having a diagnosis of permanent hearing loss by 3 months of age, and then enrollment in the early intervention system by 6 months of age. In addition, we're also trying to identify and provide intervention for those infants and children who have later onset or progressive or acquired hearing loss, to try and catch them as early as possible. So those identified at birth, but then also maybe those who had slight hearing loss or progressive or later acquired, that we catch them as early as possible to be able to provide the supports that are needed. And we want another goal is that the hearing loss will have a medical home. When we talk about some of the barriers and solutions, we'll talk about coordinated care. We know the principles of the medical home is that care is coordinated and comprehensive for the families. And the states will have the Ed.D tracking and surveillance systems to minimize the loss. So if we're going to catch them, we want to catch all of them and reduce how many get lost in each of those steps along the way. So talking about language acquisition generally and how hearing loss relates to language acquisition, we need to look at this idea of accessibility. So we know that children who have full auditory access and are born to parents who use a spoken language, they have access to the language in the environment, whether that's English or a home language other than English. When the auditory system is functioning, they have access. There doesn't need to be effort made to make sure that they can receive that information. We see the same with children whose parents use visual language. So if we see a deaf child who has deaf parents, if the deaf parents use a visual language like ASL or another visual spatial sign language, the child will have full access from birth. So they see the language around them, they have it in the home, and so that it's accessible. What happens is when we have the mismatch and we have kids who don't have access to the language. So for example, a deaf child born to hearing parents who use spoken language, even though the parents are using a spoken language in the environment, if the deaf child's auditory system is not functioning, they're not accessing the language. So they may have exposure in the environment, but without the hearing assistive technology, they may not be accessing that language around them. Also, we want to make sure for kids who are learning a visual language, that the visual language that's happening around them is also accessible. So a lot of times we may look to deaf parents of deaf children for some strategies to make this successful. So when we see some common patterns of deaf parents getting their kids visual attention before providing sign language input, we know that sometimes when hearing parents are learning a sign language, they may not be as aware of some of the strategies, like making sure they have eye contact before signing, because they're not accustomed necessarily to needing that kind of visual attention. When we look at language acquisition, an important idea here is that development is predictable. We can very much predict what kind of milestones we expect to see, what ages we expect to see them, and generally, they're pretty similar across modalities and across languages. So we see babbling emerging early. We see the same kind of, canonical babbling, depending on the language, emerging on a specific time frame with specific expectations. And if we don't see those expectations being met, they may predict later language difficulties. We see the same thing with visual manual babbling. We know deaf babies start to babble with manual signs on a similar trajectory to spoken languages. There may be some differences between the emergence of the first word. That's debated whether spoken or sign language happens first, but other than the first word, then we see very similar trajectories. We see vocabulary growth, we see two-word combinations, then we see more grammatical kind of constructions. And this predictability allows us to kind of identify what areas might be susceptible to the effects of the hearing loss. So when we look at the impacts of the hearing loss, one of the things that we often know is even though there's a greater presence of deafness in popular media, in movies, in social media, in all kinds of those kind of popular spheres, often a parent's deaf child is the first deaf or hard of hearing person they've met in person. They may not have experience interacting with deaf adults, whether deaf adults who use sign language or deaf adults who use spoken language. They may just never have met a deaf adult before. We know that the configuration of the hearing loss will impact access to speech sounds. So a child with a mild to moderate hearing loss may access some of those lower pitch sounds like vowels or nasals, and may miss out on some of those higher frequency sounds like the and we know that kids who have more severe to profound may miss all of the speech sounds, but still respond to some environmental sounds. So we know that that configuration is important, whether it's relatively flat, sloping, what level it is. We also know that a parent's knowledge or use of sign language impacts their ability to provide that visual spatial language model. So when a parent discovers their child is deaf and starts to acquire sign language, in the case, a lot of cases here, ASL, their knowledge and their ability to use the language will impact the model that they provide to their children. And how they're learning and the vocabulary they've developed, all of that will impact the kind of language model that they can provide in that visual spatial language. We also know that community resources really impact that access to visual language. So I've worked with some families who live in very remote areas of certain states, and they've decided for their family to use American Sign Language, ASL, but there's not a community around them that uses ASL. So they've had to use some kind of creative ways to engage their child, not only with the family, but with other resources like deaf mentors through things like telehealth and telemedicine. We also know the hearing loss may impact the clarity of the speech signal, not just the loudness. And this may be something that is more challenging for parents and families kind of to grasp, is that for some hearing losses, if we make them louder, they become accessible. But for others, increasing the loudness doesn't necessarily make the speech signal clear. And that may not be always the easiest concept to grasp for a family who is new to hearing loss. And we know that listening through technology is different, whether the hearing assistive technology is a hearing aid or a cochlear implant. The ability to access and process the acoustic signal will be different through a typically developing hearing versus hearing assistive technology, which may change the acoustic signal some. So we have the impacts. We've got the EHDI system is trying to reduce the negative impacts. There's a lot of impact on accessing the signal based on the hearing levels and based on the family's knowledge of visual spatial language. So what is our goal? What are we trying to achieve with this EHDI system ultimately? So of course, first is to catch and diagnose the kids with permanent hearing loss. And then ultimately the goal is to provide some sort of intervention to support their developmental outcomes. And this graph is just kind of a conceptual representation. It's not based on any specific data. It's just kind of to give an overview, of kind of how to talk about what we're doing with intervention. And we see with the blue line that we expect, again, as we're all aware, development is predictable. We expect growth in language in a very predictable fashion. And it may not be linear as this graph suggests, but overall, over time, as a child gets older, language skills increase and we kind of know what to expect and what to see. One of our goals, or the alternate is with the dark blue line, would be if we don't catch the kids with hearing loss and we don't provide the support and they don't have access to language, or they are missing important parts of the speech signal, that their skills are likely to maybe they will develop some skills, but we might expect this trajectory that separates their development and continues to divide from what we would expect from typical development. That the gap between a child with hearing loss's skills and a child who has typical hearing, that gap would grow over time as language becomes more complex, as they grow and as they may be missing certain things. So what our goals could be, as the orange line suggests, the ultimate goal would be that we achieve this age-appropriate achievement. And we have seen in the past several years that for many of our deaf and hard of hearing kids, that they can close the gap. That with the period of intervention and the EHDI goals met, that a higher proportion of kids do achieve the same language milestones as kids who do not have hearing loss. That's still not the case for all kids, but we do have a subset that is now possible when EHDI goals are met and kids are enrolled in intervention that either provides support for spoken language development or for development of sign language. Alternately, we see the gray line, which kind of suggests we're providing the support and the kids are maybe acquiring skills faster than they would without intervention, but they're not quite meeting their milestones that we would expect for their age. And then for the yellow line, kind of with some of our kids maybe with more complex needs, where we may not see the gap closing or approaching age-appropriate skills because maybe they have complex additional communication needs that are also impacting them beyond the hearing loss. But by working and identifying the hearing loss or the dual sensory impairment early, we can prevent the skill gap from widening as much as it would without that intervention. So we can bring it a little bit closer, even if the goal is not necessarily age appropriate or age milestones. So what are some of these effects that we need to consider as professionals when determining our assessment and our intervention and whether we're making progress or being successful with our interventions? And one of the interesting things is that effects of hearing loss may not be evident in the very early communication and language behaviors, which is one of those reasons we really need to have robust EHDI systems, is to capture those hearing losses, because early development may not give us an indication. We know since EHDI systems have become in place, the average age of diagnosis has decreased significantly from 2 to 3, sometimes 4, to much earlier, which is the goal. And what we see, even deaf babies early on in development will babble with their voice. Eventually, without any access to sound, that may stop. But in the beginning, we see this babbling. We see this vocal behavior that may not suggest there's a hearing loss. With kids who have access to some of those lower frequency sounds, we may see the acquisition of some of the earlier sounds that we typically see, like and b coming in early. because some of those later developing sounds that are associated with the high frequency just may not be expected and may be overlooked if we don't have a documented hearing loss that we are targeting. Early detection provides that potential access to earlier language input. We can provide access to the acoustic signal for spoken language through earlier hearing assistive technology, that whether that's through a hearing aid early on and continuing, or giving that time period for hearing aid, and if that's not successful in acquiring spoken language, leading towards earlier cochlear implantation, which tends to be associated with higher spoken language outcomes. When we identify the hearing loss early, we also have the opportunity for visual spatial language opportunities. So now we see that if a parent pursues American Sign Language as part of their communication opportunities, they can begin learning early on while their child is still very young, versus trying to learn a signed language when their child is already 2 or 3. So they're learning language to model for a 2 or 3-year-old that may be offset. So it gives that early advantage for the parents and families also to engage in visual spatial language opportunities. It provides us that opportunity for early language milestone monitoring. So as I mentioned, for a child who may have a mild to moderate or a moderate to severe hearing loss, we may see some early vocal behavior that looks like early vocal behavior for a lot of kids with typical hearing, and not being aware or attuned to the fact that we need to monitor those other speech sounds at high frequency access that maybe we wouldn't consider if there weren't a hearing loss, but we can really draw our attention to what are these acoustic or these early spoken language milestones that we may have overlooked without the presence of a hearing loss. It also helps us provide opportunities for early language milestone of the visual spatial modality. So when we recognize that the emergence of language from babbling to first words to 2-word combinations follows a fairly similar trajectory, we can look at both spoken language, but also if a family is using visual spatial language, monitoring to see if those skills are emerging on a timeline that we would expect. It also supports family and decision-making. When we know early the families can be involved in that decision-making, looking at all of their communication opportunities related to spoken and signed language. And we also, as we'll talk about later, it improves long-term developmental outcomes. I think we're all pretty familiar. The list in the chat of where everyone comes from are the stakeholders in this endeavor are broad. I'm not going to go through and describe each one because I think everyone in the audience kind of has an understanding of who the stakeholders are, who the people are that are interested in this endeavor and work. I do want to emphasize the bottom two, the parent groups and the advocacy groups, because as we talk about facilitators to EHDI systems, one that comes up over and over again is family-to-family support networks. So I think amplifying the parent groups and the importance of parent groups as stakeholders is really important. And I'm not downplaying anyone in the audience because we're all very important, but I think this is a slide we can kind of jump over a little bit. So what are some of the effective communication strategies that have kind of been documented to be supportive in this EHDI endeavor to make this 1-3-6, and then once enrolled, the intervention more successful to help support these developmental outcomes? And this goes on because with the 1-3-6, we know the one screening by one is pretty successful. You know, a lot of states and territories report very high percentages of newborns are screened. Now, when we're talking about that number of kids, even 1 or 2% is still a significant portion, a significant number. But we're doing, most of the reports are doing okay at the screening. But then we see these drops when we see the high 90s for screening, 98, 99, and then the number that get diagnosed, and then the number that get enrolled by 6 months. We see this significant drop. So what are some of the strategies that we can use to help change that so that we don't lose these families to follow up, so that we don't lose them between screening and diagnosis, or diagnosis and enrollment in early intervention, or during the early intervention process? And some of the strategies are to provide clear and culturally responsive information. So recognizing where the family is and their cultural attitudes and beliefs, and bringing the information in a way that is very clear and consistent with their cultural attitudes. Providing timely, unbiased, but evaluative information. I think often we talk about bias and unbiased, but when we talk about unbiased information, we're not talking about providing a list, like a menu, like, here's your choices, here's your options, pick one, let me know what you think, and parents and families really value the pros and the cons and the discussion of the positives and negatives of different approaches that they can take with their families. That's one of the values that families have, or one of the things that gets communicated from families is they don't just want information as a list, but also what are the positive outcomes, without going into that bias part where we're looking to use emotion over logic, or intentionally manipulate how families approach their communication selection, or dismissing certain approaches, but still providing a really evaluative, what does this mean? What does it look like? What are the pros? What are the cons? Versus just a listing of opportunities. Providing clear next steps is a value, and I saw this North Dakota Infant Hearing Roadmap, I think is a really good example of that, because it very clearly lays out what the next steps are, what the expectations are, and it's easy for parents to kind of see, read, and visualize, and know what the expectations are. Highlighting the importance of early involvement or early intervention with families is when we talk about why is EI so important? What is the value of monitoring a child's language development, monitoring their milestone acquisition, being engaged with providers and other family networks to support the positive outcomes? And then, of course, maintaining a positive and trusting relationship with family, having that ongoing trust that forms with the relationships. As I mentioned before, one of the big reported strategies that's effective for communicating is providing a support network, which can include family-to-family support networks with families who have similar situations. So we see often families benefit from other families who are making similar decisions, or who can provide insight and outlook to the families that are going through this maybe for the first time. Incorporating a family-centered approach, so consistent with the principles of early intervention broadly, engaging the family and making them the most important stakeholders of working with the family to identify what are the strategies, and empowering them to take ownership over decisions and over strategies and over that kind of supporting their young child. Providing access to resources and supports, often through the IFSP process. Ensuring continuity and coordination of care. One of the things that families report is when there is coordination of care between professionals, there tends to be less loss when the care is coordinated. And responsivity to parent needs. Ed.D has made some significant changes. The The average age of diagnosis, much younger. The average age of enrollment in early intervention, much younger. A lot of positive. We see these cohorts or groups of children who are achieving language milestones consistent with age expectations. So there's been a lot of great growth based on EHDI systems and supports, but there still tend to be quite a few barriers that keep us from achieving those 1-3-6 goals and those language milestones that we would like to achieve. Some of the barriers that are reported are economic stability, which can be for families who have fewer resources. They may have less access, or they may not have access to the types of resources or be aware of the types of resources that are available. Education level is associated with less access to, so the lower tends to be associated with less access. So when we are working with communities where educational access may be a concern, we may have to put more strategies and more supports in place to ensure those EHDI benchmarks are being met. Healthcare access, we know that for a lot of areas, being in a rural environment may make it difficult to access healthcare facilities that provide screening services or diagnostic services, or school-based services may be difficult to access. Social and community context, we see there are different beliefs surrounding hearing loss and what that means and what that looks like. Just anecdotally, one of the families that I worked with in early intervention whose child came to our school for a toddler group, during picture day, the parents asked us to remove the hearing aids for the school picture. So that reflected a kind of attitude or belief towards the hearing assistive devices that maybe was an area that we could work through and support to talk about what that looks like. Some families have also reported not wanting to use sign language in public because they feel like people are looking at them, which makes them comfortable maybe using it in the home, but then their child is missing out on some opportunities in social contexts. And that may be because of the family's belief about what sign language says about them. So kind of talking through some of those social and community factors can be barriers for child language acquisition. Then there may be some medical factors. We know prematurity, extended NICU stays sometimes impact the ability to development. We also have some barriers at the systemic level. We have some of these social community context layers that surround potentially race and ethnicity. We see the system service capacity. We may have lack of access to qualified providers, which is related to provider knowledge. One of the recommendations for working with deaf and hard of hearing infants and toddlers that the Joint Committee on Infant Hearing makes, a international panel of professionals, so that people who work with deaf and hard of hearing infants and toddlers should really be knowledgeable about the specialized needs of kids with hearing loss and hearing assistive technology, potentially the use of visual spatial language and its development. But the reality is we have a lot of providers who just have not acquired that specialized knowledge because of training or whatnot, but they are still the person who is available. And so that's one of the great things about programs like this, is that we can share some of this information so that providers can become more knowledgeable about the impacts of hearing loss, the development of spoken language as it relates in the context of hearing loss, or the development of visual spatial language in those relationships. Family knowledge may be a barrier. There may be information gaps, so loss to documentation, data fidelity, infidelity may cause disruptions in the system. Program quality can vary based on the setting and the provider. And a lot of these factors, the barriers, are factors that include factors that fall under the social determinants of health, that we see more broadly than just the EHDI system, but impact also on our kids who have hearing loss. So those are some of the problems. We know the problems. The problems are all over. What are some of the facilitating factors or facilitators that have been reported by systems or by communities or by providers that may address some of those barriers? And the overarching theme of most of these facilitating factors have been documented under this theme of meeting the family where they are. So if a family struggles to attend multiple appointments or doesn't follow up with recommendations, there may be this construct of care coordination and navigation, or co-locating services and coordination. So providing rescreenings in well baby visits is one strategy to co-locate service so that a rescreening isn't separate from a medical appointment, or having centers that can provide diagnostic opportunities as well as other kind of medical care. We see this family support, providing these family provider partnerships, and this access to family interaction comes up over and over again that we see. Financial support, one of the areas is financial burdens and barriers to access. One example of a financial support are state or local hearing aid loan banks. So while there's waiting for the process for a child to get their hearing assistive technology, they may be fit with some kind of loaner through this loan type bank so that it's not a permanent fix, but it gives them that early access while waiting for the more permanent solution. Timely and equitable services tends to facilitate the loss to follow-up. So when parents receive timely services, it can prevent the time between steps and reduce the loss to follow-up. Qualified providers with expertise on the unique needs of deaf and hard of hearing children. So again, this is a challenge for our preparation programs in early intervention, in speech-language pathology, in audiology, is amping up that knowledge base that providers have working with deaf and hard of hearing. Again, through continuing education opportunities like the ECHO series, it can reach out to more people who may not have the specialized knowledge to gain that kind of knowledge. Ensuring program quality, and then families being involved with informed decision-making empowers them to take on that role and become invested in their child's development and monitoring and language acquisition. And then data linkages with oversight help to maintain that they're not lost in that kind of data area. So what are the positive outcomes? This is what we're really trying to sell to families. We know that EHDI has significantly decreased the average age of identification. And if we decrease the age of identification, we can provide the supports through access to hearing assistive technology or access to visual spatial language support through teaching parents ASL and strategies to communicate with their kids, or strategies to support their use of the hearing assistive technology and making the spoken language accessible. It's pretty well documented that there are improved language skills regardless of modality since the EHDI has become more the standard of care. Children who are identified earlier and have access to well-fitted hearing assistive technology have better spoken language skills. That's pretty well documented. It's not that all of them achieve age appropriate, but a greater proportion have better outcomes given when EHDI objectives are met. Interesting, with a lot of families who are just learning ASL, there's a concern that they don't have the language to provide to their child. How can they be a language model when they're learning themselves? But some current research suggests that even when parents are just learning to sign, that if they are learning and they are exposing their children by 6 months of age, that the growth rate of ASL vocabulary in children of hearing parents is similar in trajectory to the children who have deaf parents. So even though it's this incomplete language knowledge, when it's provided early, it can have pretty robust outcomes. And a really important outcome is that families can develop self-efficacy in supporting their deaf and hard of hearing children. So what our goal is to center the decision-making and the intervention with the family. And when we do that, and by identifying hearing loss early, by providing that early involvement, which tends to be family-centered versus later preschool environment, which is more child-centered, we can support the family's self-efficacy in how well they can provide support for their deaf and hard of hearing kid. So part of our intervention is not only giving them the strategies and the skills to support their, but also making them feel like they are good at it. And that when we give them these skills, they can implement the speech and language skills that we work with them on a daily basis to support their deaf and hard of hearing child's developmental outcomes. Okay, so to make sure that we have time for the case study at the end, that was a lot and I went very quickly, but are there any questions or thoughts or areas to kind of go a little more, or ready for the case study? So my information is there. Feel free to contact. This will be up on the site. There's some select references for some of the information that was shared, but I will stop sharing my thing so we have time for the next person to present the case study.
There's a quick question in the chat. It says, can you share a link to the study that you mentioned about parents learning ASL?
Yes, that I can.
And it doesn't have to be right now. I'm sure we can email it out afterwards too, not to put you on the spot.
It's actually one of the references from one of the select references, so. It's not the link to the study itself, but it's the citation.
Awesome. Well, thank you so much. That was so great. So much good information. And I don't see any more questions. Will the PowerPoint be shared? Yes, the PowerPoint will be accessible on the iEcho website. And then I would love to introduce our case presenter, Tori Allen.
All right, can you see my screen?
Yes. Just in PowerPoint. I don't know if you have it in presenter mode or not.
Not sure. Let me look. How's that?
Perfect.
Perfect.
All right, I just wanted to share a little bit. I'm a parent advocate and also the North Dakota EHDI Family Follow-Up Coordinator, and I'm on the board of the Hands and Voices here in North Dakota. My daughter, Gracie, she's a young adult with hearing loss. She has bilateral, moderate to profound loss. So pretty significant. And she wears bilateral hearing aids. So some of our background, she did pass her newborn hearing screens. We left the hospital, told that we had no issues. We started noticing things as she grew a little bit older. I have a niece who is just like 6 months older than her. I was always told to don't compare them because every kid is different. Finally went to her child check right before she was 2 years old. And I think they sent me to go get to the audiologist to kind of just placate me. Found out, went to the audiologist, and we ended up with her first hearing aids at 2 years old. So we were very late in getting them those services, which really set us back quite a bit. From there, we started private speech, which turned out to not be the best solution for us. They had us stop teaching her sign language. The cost and insurance with the young family, that does become a factor, whether you want to make that a factor or not, it does. And the suggestion was to put her in the special needs preschool through the public school here in the Jamestown area. We are from Jamestown. In that preschool, it wasn't just, she was the only child that was deaf, hard of hearing. So she did start modeling, which is very common for a kiddo that is deaf, hard of hearing. So she started modeling bad behavior. From there, it was suggested that we move her to a normal preschool, which was absolutely fantastic. It really, the preschool that we ended up with did a lot, helped her out a lot. Then we started the speech services through the schools, through the special education program. And that was much better than what we were doing in private speech. Obviously, the cost was a significant factor. Also, they were able to bus her to her speech services through the school rather than us, her parents, having to try to get off of work and get her there. And all of those things. And she also learned how to ride the bus when she was very little. We do live out in the middle of nowhere, kind of in the rural community. So she has been riding the bus, or she did ride the bus for a lot of her school career. Then the decision came whether or not we wanted to do keep her in the preschool school that she was in, which was a small and private school versus the public school kindergarten. The decision there was difficult. It was, for me, it was, she was going to go into a kindergarten class with 12 kids if we kept her in the private school, or 25 kids if we put her in the public school. And for her at that moment in time, the smaller, less chaotic classroom was best for her, and so that's what we did. Of course, the public school did not like that. We did have to fight for what services we got because of the private school, which we understood. And so she did get special education services, but they were a little more limited than she probably would have gotten in the public school. We did start IEP. We had a lot of struggles with IEP because I didn't understand them. And it's a really tough for a new parent to sit down with an IEP group and talk about what's wrong with your child versus what your child is successful at. From there, that led me to seek other resources, which led me to the Hands and Voices, North Dakota Hands and Voices board, and the parents there, parent professionals are all part of the North Dakota Hands and Voices. So not only was I able to talk and connect with other parents, I could also get some more ideas from professionals, which is a fantastic program. Putting a plug in for it there has helped me out a lot through our journey, has helped my daughter out a lot through her journey. We started to advocate and understand what we were entitled to, rather than what we had to do, or what the school thought we had to do, or that type of thing. We learned that we run the meeting, not the school. They should listen. They should work with us. We had to fight for the services that we got. And I'm not saying anything against the school system or the special education. It was just, we didn't know how to navigate those meetings. So that led us to, we, meaning Gracie and I, wanted to share our story and our struggles and successes with others. And that also led me to get involved with Ed.D. and become the family follow-up coordinator. Gracie was a little older when I started this journey, which led her to also help be involved with advocacy with younger kids like her. She eventually got better hearing aids. She was able to hear her own voice for the first time. She's now in college. And she's now learning to be her own advocate. She can't rely on her mom for that anymore. So college is just a little bit different than obviously being in high school or elementary school, preschool, that type of thing. So I kind of went through that pretty fast. That's just what our journey was. And so thinking about our presenter that we just listened to, a lot of the things, the early EHDI system, those milestones would have done wonders for my daughter and for my family. So I can't stress that enough. And when I talk to new parents that have been diagnosed, I talk about those things. I advocate for those things because it makes everything easier. The earlier you find those services, the early you're identified, that type of thing. But I also talk to those families about being their own advocates, being their child's advocate. Don't take no for an answer. Don't let anyone tell you what your child can't do. Because I did that as a new parent and I didn't know I needed to do anything differently. So I really enjoyed hearing those things and getting that education out there. What I forgot to mention also in my journey is I also worked for, managed an early intervention program with the Ann Carlson Center here in Jamestown. I was not an early interventionist, but that's who I worked with. And I learned a lot of skills there as well. And all of those important things that parents have access to and the importance of them utilizing those. So that's my story. And if there's any questions or anything for me, I would be happy to answer that. Well, I appreciate being able to visit with everybody and kind of share our story. And if anyone has wants to reach out to me, I think my contact information will be on this as well. And again, Hands and Voices and EHDI, any advocacy group, family voices, they're great resources for any family going through a child with hearing loss. Thank you.
Thank you so much, Tori. That was great listening to your story. And there's lots of thanks in the chat.
Yeah.
Oh, I see a question too. Was there any skill development that you felt benefited your family?
Advocacy for ourselves. By nature, I'm a very quiet person, and so it took me a long time to be able to speak up and get what we needed. My daughter is also a very, very shy kid, very quiet. So she's learning that right now as an adult. She's 20 in her second year of college, so.
Well, thank you so much. I think a link for the survey or evaluation will be sent out after the session is over. And we look forward to seeing you next week.
We are actually posting a link into the chat,
and
yep. We are using a new feature that we didn't realize was available to us in iEcho. So if you go to the session tab, as soon as the session starts, you'll see a feedback or submit feedback link under each session. So I did have a couple people reach out and ask about session 1, so you can go back and provide some feedback to session 1 if you didn't get a chance to fill out that satisfaction survey. But yeah, so it's in the chat and then also in iEcho. And thank you all so much for being here. We hope we can see you next week. We're going to be talking about screening and diagnosing a hearing loss, and we will be featuring Jocelyn Martin from the Mayo Clinic, I believe. Thanks again, James, for presenting, and thank you to our fine interpreters for today's session.